A lovely obese 65-year-old man named Patrick Volcano was sent to us from his PCP due to some jaundice the patient is experiencing. He's of African American descent. The patient denies any associated abdominal pain at all. The PCP still got an abdominal ultrasound, which was a rather astute move, but it only showed a larger than normal common bile duct and no masses. Patrick is obese, but has been losing weight recently. He remarks he's been trying to lose weight due to his recent diagnosis of diabetes, but doesn't think he's been trying hard enough to have this much weight loss. He also reports a significant smoking history. Then he mentions that his urine is dark and his stools are very light, almost white, and are floating in the toilet. Well, I have no idea what that's about. He reports his mother was from a tiny fishing village called Octopus Island in French Polynesia, but that she moved back there when he was young and she died there. He doesn't know the details, but remembers something about her eyes turning yellow also. We're asked what the next best step in management is. Then we are asked what the curative treatment would be if there are no contraindications to it. Well, welcome to tiny Octopus Island in sunny French Polynesia. This teeny island is a monument to the world of fishing, as you'll soon see. Even though they're called octopus islands, turns out they do a great deal of business in sharks. Huh, that's a pretty scary subject, just like this sketch's topic. Let's dive in, with full shark proof gear. Patrick's main complaint of painless jaundice should be a dead giveaway for his disease, and it's not a nice one. The weight loss is also highly suspicious for cancer, and the common bile duct dilation. If you remember, the common bile duct courses right through the head of the pancreas on its way to the bowels, and that's right where the dilation was in our clinical case. So, could it be a tumor in the pancreas causing that bile duct obstruction? The ultrasound didn't show a mass at all, but then again, the pancreas is all the way behind the peritoneum. So maybe the ultrasonographer just couldn't quite see it. Eesh, pancreatic cancer. This is one of the bad ones. Instead of the good, the bad, and the ugly, you tend to only see the bad, the ugly, and the uglier in these cases. Pancreatic cancer almost always refers to exocrine pancreatic cancer, as in the ducts and pancreatic juice making cells, not the endocrine cells. The majority of pancreatic adenocarcinomas arise from the ductal elements of the pancreas, making them ductal pancreatic adenocarcinomas. Keep that ductal thing in mind, it gets real important later. Neuroendocrine pancreatic tumors are tumors arising from the endocrine elements of the pancreas, such as insulinomas, gastronomas, and VIPomas, etc. These are not covered by this sketch. Most pancreatic cancers, around 70-ish%, develop in the head of the pancreas, with the remainder in the body and tail. This is actually a good thing, as tumors in the head lead to more noticeable symptoms and subsequently earlier diagnosis. This is usually due to obstruction of the pancreatic ducts and bile ducts. We'll get to that in a second, and I'll bet it'll explain a lot of Patrick's symptoms. As with many other cancers, pancreatic cancer typically develops in older adults, with a peak incidence in the 6th and 7th decades. Just like this salty fisherman. It's also more prevalent in men than women and is seen more frequently in African Americans. Other risk factors clearly associated with the development of pancreatic cancer include smoking, obesity, chronic pancreatitis, and cystic fibrosis. Patrick from our clinical case has at least two of those. There is also evidence that family history may be important in the development of pancreatic cancer, with as many as 10% of newly diagnosed patients having a family history of the disease. Most of these are familial pancreatic cancer, in which there's a family history, but a specific gene defect has not been identified. A small proportion are genetic predisposition syndromes, with genetic mutations in known cancer predisposition genes, such as BRCA2. Huh, well, I guess fish would probably like candy too. Is that how Octopus Island does so good with fishing? I'll have to try that next time I go fishing. I wonder if sharks like candy. Another less well understood risk factor may be diabetes, though it may be the pancreatic cancer causing the diabetes. Just put a pin in this one for a minute. We'll come back to it. Symptoms of pancreatic cancer are pretty vague, which is probably why patients don't seek medical treatment quickly, sometimes even for years. The most common symptoms include constitutional symptoms, such as fatigue and unintentional weight loss. The same symptoms you'd get after a week out on the high seas trying to catch some fish. Whoa, look out! That guy's about to get crushed by those crab traps. Abdominal pain, which patients describe as gnawing epigastric pain radiating to the back, is present in most patients at diagnosis. Tumors in the pancreatic head commonly present with jaundice as a result of obstruction of the common bile duct as it passes through the pancreatic head. As you would expect, this leads to cholestasis, including elevated conjugated bilirubin levels. Common bile duct obstruction may occur relatively early in pancreatic head tumors, before the onset of abdominal pain, leading to the classic presentation of painless jaundice. That sounds familiar. Just like Mr. Volcano from our clinical case. Patients with cholestasis may also report a history of pruritus, dark urine, and light stools from the common bile duct obstruction. That's weird. And that's just like our clinical patient. Why are the colors of these two outputs switched? When bile is blocked from entering the bowel by the tumor, it backs up. Through a currently unknown process, conjugated bilirubin seeps back into the serum. It causes pruritus and jaundice and is excreted by the kidneys. Conjugated bilirubin is pigmented, resulting in the dark urine. The lack of bilirubin in the stool because it can't get to the bowels results in the light color of the stool. Pancreatic head tumors may also present with loose, fatty stools, termed steatorrhea, as a result of either decreased exocrine pancreatic function or blockage of the pancreatic duct. Remember, the pancreas is responsible for secreting enzymes that digest fats. Without them, you get malabsorption. Increased fat in the stools results in stools that float to the top of the water, and really, really stinky farts. Whew, Mr. Goat, was that you? Now, don't you try and blame it on the sharks. And no surgical topic would be complete without an eponym or two. Corsavier's sign refers to a palpable, dilated, non-tender gallbladder which occurs as a result of backup of bile from duct obstruction. It can be seen with pancreatic head cancer or even gallbladder cancer. Anything obstructing the bile ducts, really, including seagulls and non-cancerous etiologies. It's highly unlikely to be gallstones, however. Is it seen in cancer? Yes. Is it common? Not at all. It's seen in less than 15% of cases. Remember I said we'd come back to diabetes? Patients with pancreatic cancer may have new onset diabetes or hyperglycemia consistent with insulin resistance. Again, is it diabetes increasing the risk for pancreatic cancer? Or is it pancreatic cancer causing endocrine dysfunction of the pancreas? Basically, which comes first, the shark or the egg? Do sharks lay eggs? Let's ask Google. Do sharks lay eggs? And, while I'm on it, do sharks like candy? Aha, unclear. I wonder if sharks get diabetes. Google says no, but dolphins do. Alright, before I get pulled into the vortex of Googling random things, let's continue. For which comes first, the diabetes or the pancreatic cancer? Different sources and people will tell you both ways. The jury's still out, so just remember there's an association between pancreatic cancer and diabetes, and you'll always be covered. It should come as no surprise that pancreatic cancer, like other cancers, causes a hypercoagulable state that increases the risk of venous thromboembolism, particularly a rare and special kind, called migratory superficial thrombophlebitis. This is also known as Trousseau's syndrome, not to be confused with the twitchy wrist Trousseau's sign seen in hypercalcemia. With migratory thrombophlebitis, patients develop inflammation overlying superficial venous thrombosis, which manifests as pain and erythema that migrates around. Pretty, on the nose there. On exam, tender erythematous cord-like veins may be palpable. Since pancreatic cancer is often not detected until quite late in the disease, physical exam evidence of metastasis may be present at diagnosis, including an abdominal mass, periumbilical lymphadenopathy, Sister Mary Joseph's node, or left supraclavicular lymphadenopathy, Virchow's node. Wait. Is that goat tied there as shark bait? Not cool, guys. When patients present with jaundice, especially painless jaundice like our clinical case patient, it's important to do some lab work to at least guide you in which direction to go diagnostically. Since jaundice due to pancreatic cancer is due to obstruction of the bile duct, it'll have an extrahepatic cholestatic picture on labs. This means an elevated bilirubin, specifically conjugated bilirubin. which is measured as direct bilirubin. Extrahepatic obstruction also causes injury to the bile duct epithelium, leading to elevated alkaline phosphatase. In pancreatic cancer, carcinoma antigen 19-9, more commonly referred to as CA 19-9, may be elevated. Careful though, because as with other tumor markers, it isn't diagnostic on its own, but simply supports the diagnosis of pancreatic cancer. It's also important to remember that not every patient with pancreatic cancer, especially small tumors, will have an elevated CA 19-9, and other cancers, like cholangiocarcinoma, can also cause an elevated CA 19-9. Well, we ought to get some blood work on our clinical case patient Patrick. But something tells me that's not the right answer to our clinical question. For patients presenting with jaundice, with or without abdominal pain, workup often begins with abdominal ultrasound to look for evidence of a cancer in the pancreatic head and to evaluate for other causes of jaundice. We can remember from our clinical case that that's what the PCP did. It showed some ductal dilation, but no mass. In some cases, ultrasound may visualize the tumor itself, which appears as a hypoechoic, dark, solid mass with irregular margins. Tumors in the head of the pancreas, again the most common location of pancreatic cancer, frequently obstruct the common bile duct, leading to common bile duct dilation. Eventually, backup of bile leads to dilation of intrahepatic bile ducts as well. Thus, both extrahepatic and intrahepatic duct dilation may be visible on ultrasound even if the mass itself is not. But beware. Choledocholithiasis, a stone in the common bile duct, can cause obstruction and common bile duct dilation too. Sometimes, pancreatic head tumors obstruct both the common bile duct and the pancreatic duct. The dilation of both ducts behind the obstruction lead to the double duct sign on ultrasound and is very suggestive of a pancreatic head cancer. It's important to note that while associated with pancreatic cancer, this double duct sign can be seen in other diseases too, and thus is not diagnostic of pancreatic cancer. Ultrasound is very sensitive for detection of large tumors in the pancreatic head, but may miss smaller ones or ones in the body or tail. If ultrasound fails to detect a tumor but clinical suspicion for pancreatic cancer is high, the next step is a contrast CT. There's the answer to the first question. Look out, kitty! There's sharks in these waters, and they'll eat you. Huh. Well, actually, do sharks eat cats? I mean, they must, right? Ugh, you know who would know? Google.
Not now, Ricky.
Fine, look it up later. In patients without jaundice, such as those presenting primarily with abdominal pain, a CT with contrast is often the initial imaging test performed. On CT, pancreatic cancer classically shows up as a hypoattenuating, i.e., dark, mass within the pancreas. In tumors obstructing the common bile duct and pancreatic duct, duct dilation, the double duct sign, may be seen, just as it was on abdominal ultrasound. While CT is the mainstay of pancreatic cancer diagnosis, and staging for that matter, we'll get to that in a minute, in some cases, additional imaging modalities are necessary. Some brave divers in this region. Don't they know about the sharks? If there's no discernible mass on CT, but there remains a high clinical suspicion for pancreatic cancer, ERCP or MRCP may be performed to look for evidence of a tumor. ERCP, or endoscopic retrograde cholangiopancreatography, is invasive and carries a risk of complications, but may pick up strictures or small tumors missed by CT. Additionally, it can be used to collect tissue samples for histology, biopsy of masses, or cytology brushings of potentially malignant strictures. In some cases, ERCP may be performed for suspected choledocholithiasis, but cancer, rather than an obstructing gallstone, is found instead. Often, endoscopic ultrasound is performed at the same time as ERCP, which can visualize the pancreas through an endoscope ultrasound probe in the stomach and duodenum. Because the probe is closer to the pancreas, it provides higher resolution than abdominal ultrasound and can pick up small tumors not detectable with other imaging studies. Additionally, EUS guided biopsy can be used to obtain a tissue diagnosis by guiding a needle through the stomach or duodenal wall and into the pancreas. MRCP, or magnetic resonance cholangiopancreatography, a specialized MRI protocol, is non-invasive and at least as sensitive as ERCP in detecting pancreatic cancer. However, it can't be used to collect tissue samples. In most cases, if ERCP or MRCP is also negative, pancreatic cancer is effectively ruled out. So now that we've found a mass and a presumptive diagnosis of pancreatic cancer has been established based on imaging and maybe biopsy, the next step is usually staging to determine if the tumor is resectable. Staging is primarily assessed with the specialized contrast CT scan optimized for staging pancreatic cancer. Most patients diagnosed with cancer by CT scan will still need this test because the general diagnostic CT is not the same as the pancreatic protocol used for a much more detailed look. You'll most likely hear the terms CT pancreas protocol or triple phase CT kicked around. CT images of the pancreas are taken at specific times after contrast is injected, creating three phases of images. The arterial phase looks at, well, the arteries. Most importantly, the celiac trunk and the SMA. The pancreatic phase comes in the middle and best highlights the pancreatic parenchyma. Lastly, the portal venous phase looks at the SMV and portal veins, as well as metastases and lymph nodes. Oh, nice. A shark free swimmy zone. The Meg could probs get through that chicken wire, though. Surgical resection is the only chance for a cure. Usually a pylorus preserving pancreaticoduodenectomy. Whew, that was a mouthful. The surgery is better known by its eponym, the Whipple procedure. However, this surgery has a very high morbidity and mortality. Therefore, it's only performed if there's a reasonable chance it will be curative. Unfortunately, only 15 to 20% of patients diagnosed with pancreatic cancer will have resectable disease, primarily due to how late patients often present in the disease course. A Whipple is only performed if all visible cancer can be removed. Therefore, a tumor is considered unresectable if metastases are present, either distant from the tumor, like in the lung, or if there are any involved lymph nodes outside the field of resection, meaning what would be removed during surgery. Likewise, local vascular invasion may make a tumor unresectable. Most commonly, we talk about vascular involvement of the SMA, which is determined by how much of the circumference is encased by tumor. Greater than 50% involvement of the SMA or celiac trunk makes tumors unresectable. Less than 50% is often considered borderline unresectable because the artery could be reconstructed. Significant SMV or portal vein involvement, either greater than 50% encasement with tumor or intravenous thrombosis due to tumor pressing on it, has traditionally been considered unresectable. In recent years, some previously unresectable SMV or portal vein involvement has become borderline unresectable because we have the technology to rebuild them, or at least part of them, as long as there are suitable veins proximal and distal to the involved area. Portions of the SMV or portal vein can be resected and then reconstructed using primary anastomosis or grafts. What a time to be alive. Unless you're swimming with sharks. Then alive is probably more of a temporary state. A word about biopsies. Histologic exam by a pathologist is required to confirm the diagnosis of pancreatic cancer, which means tissue needs to be obtained at some point. While a handful will have a biopsy at diagnosis, for example, if they had an ERCP or EUS as a part of the initial workup, most will not. So, when do they get biopsied? Well, depends on the scenario. Those with resectable cancer may not receive a biopsy prior to surgery. The surgical specimen that gets removed in the OR will be sent to pathology for examination. Unfortunately, in the majority of patients, staging reveals unresectable or borderline resectable disease. In both cases, biopsy, usually via EUS guidance, is performed to secure a tissue diagnosis and guide medical treatment. For patients with unresectable cancer, chemotherapy is the mainstay of therapy. Radiation is sometimes added in cases of local invasion, but is not used as first line. In cases of symptoms like jaundice from biliary obstruction, a biliary stent can be placed, usually via ERCP, to relieve symptoms. Unfortunately, prognosis is very poor. In cases of borderline resectable cancer, neoadjuvant chemotherapy is usually given to try and shrink the tumor. That term neoadjuvant just refers to any chemotherapy given prior to surgery. The idea is that chemo shrinks the tumor, making it more likely to be resectable, and then surgical resection can be performed. While imaging techniques are the mainstay of staging, they may miss small metastases, usually less than 1 centimeter, particularly those on the peritoneum, also called peritoneal seeding. The presence of even small metastases makes the cancer unresectable, so finding these is a big deal. As a result, some surgeons will perform a staging laparoscopy right before definitive surgery in certain patients. The goal is to avoid starting a laparotomy, which involves a big incision, only to find peritoneal seeding and be forced to abort. If no evidence of metastases are seen on laparoscopy, the big cut is made and the Whipple proceeds. And now, the pièce de résistance. Pylorus preserving pancreaticoduodenectomy, aka the Whipple procedure, is the conventional surgery for cancer in the pancreatic head. There are other versions which have various indications and which you may or may not see, but you'll definitely talk about this one. The Whipple is arguably one of, if not the most involved surgeries today. The recipe goes a little something like this: free up the duodenum, you'll hear the term cocorizing the duodenum, then transect it proximal and distal to the segment to be removed. Then divide the pancreas. That segment of duodenum contains the ampulla of Vater. No, not Darth Vader. So you have to deal with the common bile duct also. So cut that up high. Technically, it's the common hepatic duct that gets cut. The duodenum, pancreas, common bile duct, and gallbladder all get removed and tossed to the sharks. Then a loop of the small bowel gets brought up. The pancreatic duct, the stomach, and the bile duct all get anastomosed to this limb of small bowel, and Bob's your uncle. Ah, this is the answer to the second question. The only curable treatment for pancreatic adenocarcinoma is surgery if there are no contraindications, as we discussed above. Whipples aren't just technically difficult in the OR, there's a myriad of complications in the post op period. Which shouldn't be that surprising given that you just basically took a roto-rooter to the intestines. The most common complication is delayed gastric emptying, which may cause nausea and vomiting after oral intake is resumed. While pro-motility agents such as metoclopramide may be used, refractory cases may require TPN or enteral nutrition via a jejunostomy, or J-tube. This is why many patients undergoing a Whipple procedure will actually have a feeding jejunostomy tube placed at the time of surgery. Pancreatic fistulas are the bane of the pancreaticoduodenectomy. A pancreatic fistula is basically just leakage of pancreatic fluid around the pancreatic anastomosis. Now, if you've watched the pancreatitis sketch, you know how bad it can be when pancreatic enzymes are free to roam and digest the pancreas and surrounding tissue. Think about it like a shark attack for your internal organs. If you haven't, well, let's just say that a procedure to deal with all that chewed up tissue in pancreatitis is called a necrosectomy. So that name should scare you enough. Pancreatic fistulas can lead to hemorrhage, intra-abdominal abscess formation, sepsis, and a whole lot of other bad stuff. They're typically treated by leaving surgical drains, providing nutrition via parenteral or jejunal feeding tubes, and or administering octreotide. In some cases, endoscopic or even open surgical treatment may be needed. While most pancreatic adenocarcinomas occur in the head, there are cases in which tumors arise in the body or tail. These tend to be diagnosed at a later stage, i.e., unresectable, because they don't cause symptoms until they're very locally advanced. If a tumor of the pancreatic tail is resectable, the operation isn't a Whipple, but a distal pancreatectomy and splenectomy. The splenectomy is added to ensure margins and to remove the lymph nodes that drain the area. But wait, patients aren't done after surgical resection. Adjuvant chemotherapy is given to decrease the risk of recurrence. Unfortunately, even despite optimal therapy, most patients recur and long term survival is low. For node positive disease, it's absolutely dismal. Only 10% at 5-year survival after surgery. And for node negative disease, it's still only 30% at 5 years. That's worse odds than a shark attack. On that happy note, let's summarize. Pancreatic adenocarcinoma arises in the exocrine glands of the pancreas and is typically from the ductal elements. Approximately 70% of tumors arise in the pancreatic head rather than the body or tail. Due to this location, tumors in the head of the pancreas may obstruct the biliary system, leading to more noticeable symptoms than tumors in the body or tail. Risk factors for pancreatic adenocarcinoma include age in the 6th and 7th decades, male gender, being of African American descent, smoking, obesity, a history of chronic pancreatitis or cystic fibrosis, and a family history of pancreatic cancer. There's also an association with diabetes, but it's poorly understood. The most common symptoms of pancreatic adenocarcinoma include fatigue, weight loss, and epigastric abdominal pain radiating to the back. Common bile duct obstruction from the tumor may result in jaundice, which is commonly painless, meaning there's no abdominal pain associated with it. Pruritus, Dark-colored urine and light-colored stools due to reabsorption of conjugated bilirubin back into the systemic circulation and failure of elimination of that bilirubin through the stools. If the pancreatic duct is obstructed, steatorrhea may result from failure of digestion of fats in the GI tract. Cusavier's sign is a palpable, dilated, non-tender gallbladder and is unlikely to be gallstones in nature. It's classically associated with pancreatic and cholangiocarcinoma, but may be associated with any disease that can block the common bile duct. Trousseau syndrome is the eponym for superficial migratory thrombophlebitis, which results in pain, erythema, and swelling of the superficial veins, typically in the extremities, and is associated with hypercoagulable states from cancer. Pancreatic adenocarcinoma typically presents late in the disease course, and so there may be findings of metastatic disease on exam, including left supraclavicular lymphadenopathy, periumbilical lymphadenopathy, or an abdominal mass. Labs in pancreatic adenocarcinoma may demonstrate elevated bilirubin and alkaline phosphatase if biliary obstruction is present. CA19-9 may also be elevated, but should not be used as a diagnostic tool. Typically, ultrasound is the first diagnostic imaging used and may identify either a tumor in the head of the pancreas or biliary ductal dilation from obstruction. Double duct sign is when both the common bile duct and the pancreatic duct are dilated and can be seen in other diseases as well. If ultrasound does not identify a mass, a CT with contrast should be performed. A CT may also be the initial imaging test done if someone is presenting with abdominal pain. On CT, pancreatic cancer classically shows up as a hypoattenuating mass within the pancreas. Double duct sign may be seen on CT as well. If there's still no discernible mass on CT, but still a high suspicion for pancreatic cancer, an ERCP or MRCP can be performed. ERCP allows for biopsy and cytology brushings to be performed, whereas MRCP is non-invasive. EUS can be performed at the same time as ERCP and allows for better visualization of the pancreas through the stomach. If ERCP or MRCP are negative, pancreatic cancer is ruled out. Once a diagnosis has been made, staging is the next step. This is typically performed with a triple phase CT. These phases are the arterial phase, to examine the arteries, specifically the SMA and celiac axis, the pancreatic phase for evaluating the pancreatic parenchyma, and the venous phase for evaluating the veins, particularly the SMV and portal veins. Pancreatic cancer is unresectable if there are distant metastases or if there's disease in lymph nodes that would not be taken during the course of resection. Other features that make pancreatic cancer unresectable are local vascular invasion greater than 50% the circumference of the vessel, specifically the SMA, involvement of the SMV or portal veins, again greater than 50% encasement, or if there's intravenous thrombosis. However, these veins are considered borderline unresectable more recently as technology has advanced to be able to rebuild the veins. Tissue biopsy is necessary for the diagnosis of pancreatic cancer. For patients with resectable disease, this occurs at the time of surgery. In patients with unresectable disease, this is still necessary to confirm the diagnosis and to guide medical treatment. If no biopsy was taken previously, an EUS with biopsy is typically performed. Unresectable disease will typically be treated with chemotherapy. Stents may be placed for relief of biliary obstruction. Neoadjuvant chemotherapy may be used for borderline cases to shrink the tumor. Staging laparoscopy may also be used in cases where there's no evidence of metastasis on imaging, but there's a high likelihood. This involves inspecting the peritoneum for small sub-centimeter implants that could have been missed with imaging. The curative procedure for pancreatic adenocarcinoma is a pylorus-preserving pancreatic duodenectomy, aka the Whipple procedure. Complications of the Whipple procedure include delayed gastric emptying, causing nausea and emesis, for which promotility agents may be used, and pancreatic fistula, which is a leakage around the pancreatic anastomosis and can cause severe hemorrhage, abscess, sepsis, and death if not controlled. Distal pancreatectomy with splenectomy is used for patients with tumors of the body or tail of the pancreas, and is a much less involved surgery than a Whipple. Following surgery, patients typically get adjuvant chemotherapy. Overall prognosis is exceedingly poor in these patients. You know, come to think of it, I don't see any sharks in this sketch at all. I wonder where they all are.